Assalamu alaikum. The long clinical consultation day. First scenario, Miss Keller, 47-year-old, complaining of joint pain. Please take history, examine her, and address her concerns.
Hello, I'm Dr. Iman Ahmadi, and I'm the doctor in the clinic today. I'd like to confirm that you are Miss Keller and that you are 47 years old.
Yes, I am doctor.
Hello, Miss Keller. It come to my knowledge that you are complaining of joint pain. Can you tell me more about it?
Yes, doctor. I have this joint pain since long time, since 2 years. But in last 2 months, it get worse, and I can't move my hand.
When does this pain started exactly? Hello?
Yes, doctor. It started since 2 years, but in last 2 months, it get worse.
So does it is it sudden or it is a gradual course of the DC of the pain?
Gradual, doctor.
Is it increasing or decreasing or it is the same?
It comes and goes. And sometimes I feel well, and sometimes I feel pain.
Okay. Can you describe the nature of this pain?
Yes. I don't know, doctor. I don't know how to describe the pain, but I can't move my hand.
For example, is it a burning pain or a dull aching, or it is electrical light shock pain?
No, it is maybe dull aching pain.
It's dull aching pain. Okay. Can I see your can I see the site of the pain? Can you show
both hands? Okay. Well, okay.
Okay. Is this associated with some? Can you describe the severity of this pain from 0 to 10?
7, doctor.
I'm sorry to hear that. I'm going to offer you some painkiller. Okay.
I took already, doctor. No, thank you.
Okay. Is your pain associated with any stiffness in the morning?
Yes, doctor. You are right. I feel stiffness, especially in the morning.
So does this stiffness, for how long does this stiffness stay in the morning?
About 1 hour.
Okay. Does this pain radiate to anywhere else? Does it go to anywhere else?
No, doctor.
So is this pain associated with any swelling?
Sometimes I feel my hand swollen, and sometimes
okay.
not so.
I'm sorry to hear that. So does anything improve your pain?
Yes, when I start to use my hand and start movement, I feel it is better.
And anything worse in it?
I notice that when I stay without any movement, I feel pain more.
Any shock, any electrical shock pain in the night?
No.
Any pain in the tip of your finger, or any discoloration, especially when you are exposed to cold weather or to any cold substances?
No.
Okay. Is there any skin rash?
No.
Is there any skin rash in the present or even in the past? Any skin rash which had increased with sun exposure?
No, I can't remember any skin rash.
Okay. Is there associated any muscle pain?
No, no muscle pain.
Any soreness in your mouth?
No,
Any soreness in your private area? I'm sorry to ask you this.
no, doctor.
Any tummy pain?
No,
Any loose motion?
no, doctor.
Any change in your water work
No, it's normal.
or pain or burning pain
No, doctor.
in your water work or frothy urine?
No.
Any pain in your eye or redness?
Sometimes I get some dryness and redness in my eye.
Sometimes you had redness and dryness in your eyes.
Yes.
Okay. So any kind of so I'm going to ask you about do you have any tight or shiny skin or difficulty in swallowing?
No, doctor. I don't have.
Okay. Did you had I'm going to say history of recurrent miscarriage or clot or blood clot in your family?
Miscarriage, I didn't get pregnant before.
Okay. So can I ask you some question like, do you have any difficulty of breathing?
Yes, I feel that I'm breathing.
So is it associated with cough?
Yes, doctor.
Can you describe the cough? Is it dry or it is associated with phlegm?
It's dry, doctor, not phlegm.
It is. Is there any chest pain?
No,
Did you ever come awake at night in order to grasp air?
no,
Do you have any associated limb swelling?
no,
Do you sleep using many pillows under your head?
no, doctor.
Is that any pain in your knees?
Sometimes I feel pain in my knees, but the most in my hands. More in my
But most of
hands.
the most of the pain is in your hands. I'd like to ask you, did you what are you doing for living?
I'm a teacher.
Can you repeat again?
Teacher.
You are a teacher. So how much the symptoms affect your job or impact your job?
Actually, this not impact my job, but in my in general, in daily life in general. When especially when I walking in the morning, I can't do I can't prepare the breakfast and I can't do anything before 1 hour.
Okay, I'm sorry to hear that. Are you smoking?
No, doctor.
Are you taking some alcohol?
Occasionally.
Okay, I'm gonna have you any kind of I'm gonna ask okay, can I examine you, please?
Here,
First of all, I'm gonna examine your hand. I'm gonna bring you a pillow, okay, so you can rest your hand over it, okay?
okay.
Is the pain that you had I can see that you had I'm gonna see yes, I can see I'm going to see some deformity. I can see it. I'm sorry, but anyway, I just can you just extend your joint?
I can't, doctor.
Okay, I'm gonna ask you to tilt your I'm gonna ask you to tilt your hand as I do. And I will if you feel any pain, just to tell me.
What will you do?
There is no pain. You are
What you did, doctor?
I'm asking you to hyperextend your wrist And if you Alice,
I,
and if you feel any pain, just tell me.
I know I don't feel pain now.
वो यार
Okay.
पीछे पेड़ से निकल गए बड़ा हो गया
Is there any scar? Is there any
नहीं
scar?
रात को आया पीछे
No scars. No.
वो भी वाला
Any wasting?
No.
Okay. I'm gonna examine. So I'm going to yeah, excuse me. I'm just gonna examine your the pain, the area that you had pain on it. If you feel any discomfort, just tell me. Okay.
Okay.
Is there any? I'm going to examine the deformity, and is there any pain when when I touch it?
Where?
Is it hot? I'm going to examine it with the
Yes.
back of my finger, with the back of the dorsum of my hand. Is it hot? Yes, it is hot.
Yes. Mild,
Okay.
mild increase in temperature.
Okay. So I'm going to examine this swelling. Okay. And I'm going to dig it. I can see that there is. Okay. Is it any crepitation?
Chance no.
Okay. I'm going to examine your elbow. So can you just flex your? Can you flex your elbow? So I'm going to see if there is some nodules in the end of your in the tips of your elbow.
No nodules.
Okay. I'm going to do. I'm going to see. I'm gonna do the tunnel test, and that's by tipping over the medial area over the carpal tunnel area. Does it elicit any pain?
No.
So I'm gonna put you some coin over the pillow. Can you pick it up?
Yes. That skin normal.
Okay.
You
And
mean big coins?
yeah,
Okay. I pick them by difficulty.
by difficulty. Okay. So I'm gonna examine your hand grip for any weakness, or is it your hand grip? Is it okay?
Okay.
Okay. I'm going to examine. I'm going to examine for proximal myopathy. Okay, and that's by seeing passive and active against resistance. Is this any weakness?
No weakness.
Okay, I'm going to examine your eye for any redness.
Yes, might says redness. Yes.
Okay, for any anemia,
Mild bottle.
jaundice.
No.
I'm going to examine your mouth if there is any ulcer.
No. No.
So
No.
I'm gonna auscultate your I'm gonna auscultate your chest for any wheezes.
No wheezes, but there's the bilateral visual crepitations.
Yes, I'm gonna ask you to
Fine.
cough and to see if this crepitation is still persistent or not.
Still present.
Okay. And I'm gonna examine the second your heart, and especially the second pulmonary area. Is there accentuation of the second heart sound?
Not accentuated or not palpable by the fish.
Okay. I'm gonna take the vital signs.
Vitals.
For
2 minutes left.
Okay, so can you tell me, and I'm going to examine your abdomen. Is there any loose, your abdomen, any tenderness?
No tenderness, no organomegaly in abdomen.
Okay, any lower limb edema?
No.
Okay, so what is your concern?
But I have to.
Yes, you had a condition which is called rheumatoid arthritis. And actually, it is a disturbance in the defense mechanism, which mistakenly attack your joint instead of attacking bugs. And it also attacks your lungs and even your eyes. Any other concern?
This curable condition, doctor?
I'm going to run some investigation and some tests and some imaging in order to confirm the diagnosis. Okay, and after that, we are going to do. I'm going to refer you to a medical multidisciplinary team. Okay, which is the joint doctor and also the joint doctor the chest doctor, and we're going to make investigation. And once the disease is confirmed, we are going to give you some medication. And actually, it is the disease can be controlled by medication. Is there any concern?
Yes, doctor. I want to get pregnant. Can I get pregnant with this condition? I know I'm 47. I want to. I didn't have kids.
Yes, actually, you can get pregnant because the disease, it will not affect the pregnancy by itself, but it had to be planned because some medication cannot be given during pregnancy. It will affect the baby. So before getting pregnant, it had to be planned. Is there any other concern?
So what will you do now?
So we are going to run some tests, okay, and I'm going to refer you to the multidisciplinary team and to confirm your diagnosis and to tell you the final the results of the investigations.
Yeah, time is up. Let's go to exam question. Dr. Marwa, please.
Okay, present your case, please.
The patient had features of rheumatoid arthritis, which is like this one neck appearance and like also the boutonniere deformity. And the patient has the signs of active synovitis because it's hot and it's swelling, and there is also tenderness. So there is effusion, as you can see, and the disease is complicated by redness of the eye, and it's also complicated by pulmonary fibrosis.
How will you manage this patient?
First of all, I'm going to run investigations, which is apart from the basic investigation, I'm going to do investigation to confirm the diagnosis, which is the anti-CCP, the rheumatoid factors, and I'll also do ANA and double-stranded DNA in order to exclude systemic lupus erythematosus and other. The patient, as he told me that he had dryness of the eye, I'm going to run the investigation of the Sjogren. In order also to exclude if it is associated, if it is a mixed connective tissue disorder. And I'm going to do anti-RMP in order to exclude mixed connective tissue disorders. That's regarding to confirm the diagnosis. And I'm going to also do investigation to confirm the complications. I'm going to run some chest X-ray, high resolution CT scan, and the pulmonary function test. Okay, and I'm also gonna do some X-ray on the hand of the patient in order to see any soft tissue swelling, any narrowing of the joint space, or if it is complicated by erosion and osteoporosis.
What?
Okay. Yes, and
Continue.
after this we can decide the treatment.
What medication do you want to give the patient?
Actually, because the patient is in the active is in the acute attack, so I'm going to give him steroids because he's in the active attack, and I'm going to give him a painkiller. But after this, in the once the patient will be in the maintenance period, I'm going to give him a maintenance treatment. But here I had a concern because the patient now is complicated by pulmonary fibrosis, so methotrexate will not be as a drug of choice as a disease-modifying drug, and even lefonamide, I will not give it. So I'm going to be restricted in giving the medication for the patient. Actually, I can give as a DMARD hydroxychloroquine and the sulfasalazine because also the patient is in pulmonary hypertension and in the same and also the patient want to be pregnant. But actually, it's not my job. It's mainly the job of the chest doctor. Secondly, the second thing that I'm going to do, if I'm going to start to DMARD and the patient is not going to be responsive, I can begin with biological treatment. And because the patient also had pulmonary hypertension, had pulmonary fibrosis, there is some drug which can be given and show some benefit with pulmonary fibrosis, like pirfenidone and the 90-darnib.
I don't have any questions, Dr. Batem.
Okay.
Yeah, I have question. When you decide to start biological therapy?
Actually, I decided to start biological therapy after I give 2 DMARD and the patient is still having activity of the disease.
After how long?
Um, after how long?
Yeah.
After giving him 2 DMARD, and he's not responsive.
Yeah. For how long?
No, actually, I don't know. I'm not so sure.
Okay. What biological therapy you know? What the options?
Infliximab, etanercept, rituximab, and tocilizumab, something like this.
Adalimumab, you mentioned adalimumab,
Infliximab,
infliximab,
etanercept,
yes.
and rituximab,
TNF, yes. Okay.
and tocilizumab. Zimab.
Okay. But I don't think tocilizumab one of them. I'm not sure, but I remember etanercept, adalimumab, and anti-TNF.
Rituximab. Okay.
Anti-TNF, yes.
Yes.
Infliximab. Okay. After 6 months of both DMARS, if no response, you can try biological therapy. What test you have to do
Okay.
before starting biological therapy?
I had to screen for TB. Okay. And I'm going to screen for TB by which is interferon gamma release assay. Okay, for latent TB. And I'm also going to do some or tuberculin test.
Only
The
TB
trick,
you will screen for?
no, I will also screen for any viral infection like HIV,
Okay.
HPV,
Yeah.
and HCV,
Okay.
and for any living vaccination if he is taking any living vaccine.
Okay. You mentioned you will not do this by yourself. So what the best option you will do?
Refer it to the chest doctor.
Only
To
chest?
the, and the
What
joint,
we call?
the chest doctor and the joint doctor.
So what we call this?
A multidisciplinary team.
Yes, exactly. So better to mention them before saying all these options. Okay.
Yes,
Rheumatologist
I
as
say
well. Yeah.
yes.
Yeah.
I say to the patient when he asked me about the plan of his management. But I
Okay.
respond to this to the examiner question.
Okay. Well done, Dr. Iman. Let's hear Dr. Marwa comment, then I will comment. Dr. Marwa, please.
You can comment, doctor, from start.
Yeah, you have to
I
comment
think
about the case. Is it overlap syndrome, rheumatoid overlap, or is
it's
it?
pure rheumatoid case, not
Yeah.
diagnosed with pulmonary fibrosis.
Yes,
Newly
exactly.
diagnosed, yes, by
Yes,
Okay.
but it depends because maybe the anti-RNP are negative, and that's why we decided that it's not overlap
Hmm?
or
Mixed connective tissue.
ah
Yes.
Well, no other manifestation of other than rheumatoid arthritis.
Sjogren is
yes,
associated. There is Sjogren.
yes,
Or
Sjogren is, yeah, maybe it is related to rheumatoid arthritis also.
yes, you're right.
It's
Sika syndrome. Yes, it might be associated with rheumatoid without Sjogren. Yes, you're right.
yes.
Keratoconjunctivitis sicca. Yes. Okay. Okay. My comment for Dr. Iman, the systemic review. Yes, you won't roll out other association, but you went randomly from system to system. I think you didn't ask about CNS at all, right?
Yes.
Yeah,
I really
that's
focused on
yeah.
the most relevant systems.
So if we start from the relevant system here, I prefer before starting analysis of the relevant system, I prefer to ask about previous attack. I think you didn't ask about the previous attack. So you yes, you ask about this onset. It was all of a sudden, but you didn't ask about previous attack. Such people, they might have previous attack of joint stiffness or joint pain, or even
because I told her it started since 2 years and
Yeah.
on
In the onset,
relapsing
yes.
remitting
okay. So
course.
When I,
it was since 2 years and
Mm.
no previous attack, only from two
Good.
years back. Okay,
Yes.
yes,
okay, clear. But I prefer to keep it in your mind. Why? Because this question you have to ask it in any scenario, any previous attack. Some scenarios it will not be clear that he has previous attack, and you have to mention it and to show the examiner that you are asking about past history. Why? For example, FMF, one of the condition might have recurrent abdominal pain. So the patient now will come with abdominal pain, yes, but you have to explore if he has previous abdominal pain. So put this question in your scheme. Any
So,
previous attack?
doctor, I'm a little bit confused because when I
Yeah,
asked her when was the first time in the onset of the pain, when was the first time that it happened? She told me 2 years ago. So, am I supposed to ask another time in the past history if there is any attack before?
yeah. Some patients, they will tell you about the last onset, but if you ask more about the previous attack, she'll tell you, yes, I had it before and I received, for example, medication. I was fine. It's not for this per se, for this case. I mean,
Yes,
for
yes, in
in
general.
general. Yeah,
Yes,
put it in your scheme in order to pick up any previous attacks. It
yes.
will help
So,
you to diagnose. Yeah,
in the past history, I will begin. Is there any attack like this before?
yeah.
In order
So
to help me.
onset course duration, any previous attack. Put it in
Okay,
your question, onset course duration.
okay.
And the good thing here, you ask about the pain scale and you offer painkiller if it is more than 5, which is
Yes,
perfect. The stiffness duration here is very important and it's essential to diagnose rheumatoid arthritis more than 1 hour. I think you asked this question, any stiffness and for
yes,
how long? Yeah, it's
yes,
important
yes.
question
And she
for
said one
rheumatoid.
hour.
Exactly. This is the relevant system, the joint or the rheumatology as a complaint. Still, we didn't ask about the relevant system. You have another questions related to the relevant system as musculoskeletal, back pain, and
Mm,
joint or sorry, skin rash. You have to ask about this
yes,
question. Yes, skin rash you ask already. Tightness you
yes.
ask.
But I
Exactly.
forget. Yes, I forget that thing. Yes,
SLE SLE question you ask. I think the skin rash on exposure to sun, dryness in the eye. All this question for the relevant system, which is rheumatology, muscle
yeah.
pain, and difficulty of climbing the stair or difficulty of combing your hair.
Yes,
This is for dermatomyositis.
yes,
And you ask already for the miscarriage to roll out antiphospholipid antibodies. Difficult swallowing, you can ask it here, or I prefer to ask it in the GI questions. Why to roll out systemic sclerosis? However, if you have skin tightness, you might diagnose systemic sclerosis, right?
yes. I asked it with the other while
Yeah,
exposing other rheumatological. I asked it about any tight skin or shiny skin or
yeah,
difficulty in swallowing
perfect.
in one phrase.
Yeah, so you can ask it as the relevant system. Why? Because this is mixed connective tissue association. You can ask it,
Mm,
or you can ask it in the GI as a systemic review. Okay, let's go to the systemic review in quick manner. Any headache, any pins and needles, any weakness. This is for
okay.
CNS. The vision, you can ask here any vision change, any redness in your eyes, any dryness. However, if you ask the dryness before as a Sjogren, no need to ask here. But any vision problem is very important. Okay.
Yes,
Then the cardiovascular or thyroid, you can ask about thyroid, any intolerance to any weather. Then the chest, any chest pain, any awareness of heartbeat. Here is important as association with anemia. If there is anemia of chronic disease, the patient might have awareness of his heartbeat. Chest pain might
yes,
happen. Yes, there is association of ischemic heart disease with rheumatoid arthritis, right? The short of breath and chest symptoms. It's very important here. You have to ask it differently in the systemic review. If you want to ask as a complication, better to be in the systemic review. Why? It's supposed to have either cough or short of breath. And as you said, what the type of the cough, it's important. And of course, the patient will have it with exercise. Now the GI, any difficult swallowing, any mouth sores, any loose motion or change of the bowel habit, any fullness or discomfort in the tummy. What do you think about the discomfort? Why I will ask this question?
discomfort in the tummy. I had many things. Number one, I I can also exclude the IBD. Um,
Discomforts. Tummy fullness. Discomfort.
uh,
Point to what?
or amyloidosis as a
Okay.
complication, or IBD,
No, no, it's not IBD.
because the patient in this case, she said that she had some problems in her eyes.
No, something else.
Um, uh, so let me see, in the abdomen. Um, no, I cannot get it, I think.
Guilty syndrome.
Oh yeah, Felty syndrome with splenomegaly. I
Yeah,
completely
yeah.
forget it.
Yes.
Yes,
Either here or the examination. It's important. Okay.
yes, yes.
The GI, we finished the GI, genitourinary. Any change of the water work? What do you think the possibility here? Why this patient
Number
might
one,
have? Yeah.
any change in the water work, because, for example, if it is if there is frothy urine, there'll be amyloidosis. If it is associated with some pain during urination and stuff like this, it may be reactive arthritis.
Yeah. So either
React-
related porosity, either amyloidosis or
uh,
non-steroidal effect to the kidney, right?
yes,
So
yes,
it's important to know. You might be asked about this question. What do you think the
yes.
kidney affection in this scenario?
The kidney affection in this scenario,
Yeah.
it may be, I had many things. Number one, I had amyloidosis, so that'd
Yes,
be
perfect.
frothy urine.
Yeah.
Number two, as you just mentioned, that the patient may have a non-steroid for a long time, and it make analgesic renal disease, or renal affection, and maybe systemic lupus erythematosus. Maybe it can lead to
Perfect.
many changes in the
Yeah.
kidney.
Yeah. Lupus nephritis. Yes, perfect. So either this or this or that. You have to ask about genitourinary. Already we asked about musculoskeletal, so no need to ask in the systemic review. So you'll skip now to the family history, to the travel, and HIV question. Don't miss the female questions. I think
Yes.
you ask about only miscarriage, but you didn't ask about any other miscarriage only, but you have to ask about pregnancy, right? She told you I
Yes.
don't have, right? Pregnancy and period and
Yes.
miscarriage. You
Yes.
have to ask about the three questions.
Okay.
Yeah, the casual relationships as HIV, it's important, especially if you have splenomegaly, for example. So be ready to just roll it a question as a quick question about HIV and casual relationship. You have any partner, any casual relationship, any recreational drugs, and the past medical history here is important about the medication, the past surgery, procedure, or allergy. You have to ask all these questions.
So, doctor,
The
I just would like to ask you something, doctor.
yeah,
If the time is not enough, am I supposed to ask all the systemic review or the most relevant system?
if the what again? If the
If the,
history?
if the time will be not enough with
No,
me,
no, it
or
will be
answer.
enough. It will be enough if you
Okay.
ask quickly. But please
Yes.
remember, you start from the head down to the toe. So the head CNS, as I start and as I explained, try to do it
Yes.
in another case. You will not take
Yes.
time. If you
Okay.
if you waste a lot of time, you can skip HIV question, for example. But family history
Okay.
is crucial, and also
Yes.
the travel history is not important here, I believe. So you can skip to the social. Do you smoke? Do you drink alcohol? Driving here important because of eye affection, and the job affection to the job and the impact on the job. Then the examination. I think the examination steps you covered well, starting from the hand, put it in the pillow. This is important, very important to do. But before that, you have to ask about vital signs, the patient look, or a general look, any surrounding. Some patient they might have wheelchair, for example, if they have other association or knee arthritis, for example, particularly old age. So try to inspect the surrounding before moving to the patient examination. The hand
Uh,
examination
uh,
now. Yes,
Dr.
go
Bassem,
ahead.
can I ask you something?
Yes, sure.
If I think that I'm going to take a lot of time in the hand, and
Yeah,
it's one of the most important organ, can I begin with it,
yes.
or I had to begin with the
Yes,
vital
sure.
sign?
No, no, no. If you have short time, try to start with the hand. And while
Okay.
examining the hand, you can ask very quick question. Can I know the vitals of the patient? That's it. Okay. Why?
Okay.
Because the hand, you will do three steps: look and feel and move. Look and feel
Yes.
and move. And I think you did all of them. Look for deformity. You have to point to the deformity to show the examiner that I picked up this finding, and also to show the other ulnar deviation, the Z-shaped thumb. This is very important. Other apart from the boutonniere and
Mhm.
swan neck, all these are important.
Okay.
This is for the look. Feel for effusion and warmness, and compare always between the hand itself and above the wrist. You have to do
Yes.
it by the dorsum of your hand to show the
Yes.
examiner. And the swelling, you have to palpate all the joints. You can
Okay.
spare the distal joint because the rheumatoid is
It
not
doesn't affect it.
sparing the distal. Yes, exactly. And now the time for the function. Prayer sign and reverse prayer sign you can start with, and pick up a
Yes.
coin or button and button your shirt. Okay. The
Mhm.
complication in the hands, carpal tunnel, you offered, but don't examine before offering. Can I do this or no? Do you have any pain here? If he has pain, ask and offer. I can examine or no. If the examiner said no need, you can skip. The skin tightness, if there is skin tightness, Raynaud phenomena. Yeah, we didn't mention the history Raynaud, but you did it perfect. You can ask about any change of the color of the tip of your finger uh, to the cold exposure. Calcinosis is important also as a CREST association, systemic sclerosis.
Yes.
If you have tightness, you have to go up, below, and above the elbow. It's very important
Yes.
for the
Yes.
limited and the diffuse.
Yes.
Proximal myopathy, you have to do. Now the face examination for the heliotrope rash, for the redness in the eye, for the
Yeah.
jaundice, for the pallor, shower sign at the back. Don't forget the
Mhm.
shower sign, and the mouth for soreness, dryness, raised GVP for right side heart failure.
Yes.
The apex is very important. Sometimes you have displaced apex as a complication of pulmonary hypertension. And the pulmonary hypertension you didn't examine in this patient, you have to do. It's important. Why?
Yes, I do. I auscultate the
Yeah.
second pulmonary area, and
You did?
I,
Okay.
yes,
Okay.
yes, I do it.
So loud B2 or parasternal here. The time now
Yes.
to examine the back for bibasal crackles, inspiratory disappear or not with the cuff. And expansion, you can also offer expansion. It would be limited expansion.
Okay.
Yeah, you can offer also the dullness or tapping or percussion for pleural effusion. It might be associated, but
Yes.
you can do next the abdomen examination for felt abdomen splenomegaly for felt syndrome. It's important
Yes.
here.
Yes.
The knee for any osteoarthritis, and the leg for edema.
Okay.
This is the classic, and this is the ideal and optimum. But according to your time, do the priority according to the finding in the history. Don't do all the things. Okay.
Yes.
Yeah.
Yes.
Otherwise, in the discussion, I prefer to start with multidisciplinary team. This disease is one of the multi-system affection, right? So you might have
Yes.
the rheumatology involvement along with the chest, pulmonology, and cardiology also. Sometimes if they have pulmonary hypertension, the dermatology, if there is systemic lupus, for example, nephrologist. You have a lot of teams here. But I prefer to mention to the patient himself or herself we will refer you to a group of specialists. Don't say multidisciplinary team. It's considered
Okay.
as German. So we will refer you to group of doctors or
Doctor,
specialists.
I told her, I'm sorry to interrupt you. I told her when she asked me about what you are going to do, what is my plan, and I told her all this. But if the doctor asked me about the treatment, I had to do that. The multidisciplinary team will decide, or I can say this, even if I am an SHO, I'm not a rheumatology doctor.
Yes, dermatology only you can offer the medication by yourself. But if not,
Mm.
you can refer to the rheumatology and start by multidisciplinary team approach. And always
Yes,
start with the non-pharmacological option, which is education, counseling about the condition and the complication. You have to tell the patient how she can deal with this disease in the future, right? It's very
yes,
important because some of her daily activity might be affected. So you can refer her to occupational therapist and physiotherapist. Very important team in this multidisciplinary team approach. You have to mention the physiotherapist along with the occupational therapist. Okay.
okay, yes, yes,
The pharmacological always comes at the end. They will not speak in details about the pharmacological option, but there is some question they can ask, as I asked earlier. When you can start biological, what tests you have to do, give me options, and what the indication to start the biological.
Mhm.
All these questions might ask you. One important point: the patient concern about the pregnancy. Yes, instead of giving her the option of medication, you can say, "We will refer you to the woman doctor, and you should
Mhm.
have planned pregnancy, as you did."
Uh,
But don't tell her leflunomide or the other medication that it will affect. Sorry.
So all this stuff I will only all these answers I will only give it if the examiner asks me about them, but I'll not offer these stuffs to the patient. Is it right?
Yes, exactly. Yes.
Yes,
Better not
yes,
to give options as a pharmacological to the patient by yourself. You are not rheumatologist. You are not treating the patient by yourself. You are in one of the teams. You are not the whole team. Okay.
okay.
Yeah, this is the case, and I hope all of us understand the case and the approach was okay for all of you. Any question?
Doctor, I had a question.
Yeah, yeah. So
When she told me that she had some dryness in her eyes and so on, um, how do I exclude which is a mixed connective tissue disease? I had excluded it by the anti-RMP, but am I supposed to do a further test for Sjogren in order to exclude that it is not either than or apart from the anti-RMP to exclude that it is mixed connective tissue?
yeah, anti-RMP is diagnostic for mixed connective tissue. But how about Sjogren? Do you think there is antibodies for Sjogren? Do you
Um,
know? Yeah,
I, I, I- yes, I know that there is, but actually I had forgotten that.
anti-Ro, anti-La, right? Anti-Ro,
Yes, yes,
anti-La.
actually.
And there is also salivary gland biopsy, and there is Schirmer test for the dryness. But the antibodies, anti-Ro, anti-La.
So I just gonna ask you something. In this case, the patient told me that she had dryness in her eyes. So I had to put in, if you ask me about what are the investigations that you are going to do, I'm gonna confirm the rheumatoid arthritis by anti-CCP and so on.
Mm-hmm.
I had to tell him that I gonna do anti-Ro and anti-La. I had
Yes,
to say that.
yes,
Yes,
you will
okay.
you will
And
do
take a
screening.
biopsy.
You will
Yes,
do
and
a
take.
screening. Biopsy maybe as invasive test, you can do it later on. But by the
Mhm.
way, every patient with a connective tissue disease, you are screening all the antibodies. You will not do only rheumatoid factor and anti-CCP. By the way, you are doing all the screening tests.
Mhm.
Anti-RMB, anti-Ro, anti-La, even anti-Smith, anti-double strand. You don't know what's coming in the future. This patient might have the features of systemic lupus hidden now, and the patient will have it later on. So usually,
Okay,
when you screen for one of them, you are screening for all the connective tissue disease or the autoimmune disease association, either systemic lupus, or as I mentioned, Sjogren, systemic sclerosis antibodies, all antibodies, and always put the priority for the manifestation. For example, if you have systemic sclerosis manifestation, now you have to mention the anti-scleroderma 70, right?
Yeah.
So you will put the antibodies according to the finding in the top. Then later on, you will screen for the others.
So can I respond in this way? I will do number one, the routine test, and then to confirm the
رحيمة
diagnosis.
جيبي شاي سوا سوا كوب مال شاي أنا
As
ما
I said,
بشرب.
Yes,
today
yes,
I'm gonna do
I
anti-CCP
agree.
and
I
yeah,
agree to
yes,
start with this way, as I prefer always
yes,
the approach for any investigation. I will do the general investigation, specific investigation, bedside investigation,
okay,
imaging, and invasive test. If you ask me every category, you will find at least two tests to do. For example, what
yes.
bedside test you do here?
Bedside test for in rheumatoid arthritis.
Yeah.
Um, I had nothing in my mind.
Okay, so
ESR,
easily. No, no, it's are one of the investigation, blood investigation. Bedside test something you have to do beside the patient. ECG,
like urine. Mm-mm.
ECG, right? ECG, one of them.
Yes.
Echo,
Mhm,
right?
mhm.
X-ray joint, right?
Yes.
All these for, and also urine dipstick. It's one of the
Mm.
bedside test.
Yes.
What I mean, if you make your answer systematic, you will get more marks. I,
Yes.
I believe if you do investigation in this approach, you will gain a lot of marks. Why? Because you are showing the examiner that you are not randomly doing the tests. You are doing
But
them specifically and systematic approach. Chest X-ray,
but
don't forget it, and the high resolution in the imaging. Invasive
Mhm.
test here, you can, if you think there is lupus nephritis, you can consider renal biopsy, for example. If you have systemic sclerosis, you can do endoscopy. So every test or
Yes.
every category, you might have one test you can give as an example.
Doctor, but the problem is that a lot of doctors say it in different ways. For example, there is some doctors who say that we can say that I'm going to do basic, apart from the basic investigations,
Okay.
I'm going to confirm the diagnosis, I'm going to exclude, I'm going to confirm the complications, or investigate for the complications and investigate for the other system affected. They do like this, you know. They,
Okay. Do whatever
I don't know
you
which
are.
one is better. I don't know
No,
which
no.
one is better.
Do whatever you are comfortable with. But what I
Yes.
mentioned also, you can investigate, and it will show you that if you have complication. For example, if you
Mhm.
mention the imaging, what you will do in the image, high resolution CT chest, right? For what?
Yes.
For interstitial lung disease. This is one of
Yes.
the complication. One of
Mhm.
the bedside test echo. Echo Y, I will assess for right side and pulmonary hypertension. This is one of the
Yes.
complication. So
Yes.
it's the same. It's the same, but different
Mm.
approach.
Approach. Yes. Yes.
Okay, so whatever you are comfortable with, follow, but don't run and don't rush to give the investigation without systematic approach. Don't say, I will
Yes.
do NCCB, I will do a rheumatoid factor.
Yes.
What about the routine test? You will not do any CBC here? Do you think the
No.
CBC in this patient will be normal? No, this
And
patient might have,
no
yeah, might have.
anemia. Yes. And infantile syndrome, she may have thrombocytopenia, I guess.
Exactly. So you might have other finding you can pick up from the routine investigation, CBC, anemia,
Yes.
leukocytosis, ESR, inflammatory
Yes.
markers,
Yes.
very important, CRP. All these
Yeah.
things will help you to diagnose the association and the complication. Whatever the approach, do what you are comfortable with. Okay.
Okay.
Any other question, Dr. Iman?
No, thank you.
Okay. Any question or added suggestion from others? You can post your scenario for Dr. Marwa, Dr. Iman, please.
Okay. Just 1 minute.
Any comment from others? Dr. Aisha? Okay, anyone has
Um,
comments? Yeah.
can I write it in the WhatsApp?
Anyway, yeah, anywhere you can write and I will share it here. Anyone want to add any missing point? Okay, systemic sclerosis also as association or as a complication, you might have bacterial overgrowth syndrome.
Yes, yes.
Yeah, remember it. It might be the cause of diarrhea. If this patient is having diarrhea, you can mention it. Okay.
Okay.
Any other comments? Okay, Dr. Marwa, your scenario. Mr. Max, 43 years old, coming with joint pain. Okay, another joint pain. So it's good to be in the same topic. I hope you will do the approach as I mentioned, or whatever you want to do. But please be systematic, Dr. Marwa, okay?
Yes, sure. Hello, good morning.
Good morning.
Can I confirm you are, sorry, my name is Dr. Marwa, one of the doctors in the clinic today. Can I confirm you are Mr. Max and you are 43 years old?
Yes, I am.
Mr. Max, we are here today to discussing some issues related to your health. Is that okay? And I'm going to examine you also. Is that okay with you?
Yes, it is.
Can you tell me what bring you today to the clinic?
So actually, I come with I had since a few days some pain in my joint, in my knee, and yes, some pain in my knee. Yes.
Since when?
Since 1 week.
In both knees?
No, in one knee. Yes, in both knee.
Okay. Is this the first time to have this pain?
Yes, it is. Yes, it is like this, doctor.
Any history of trauma
No,
or falling? Okay. Um, is there any swelling or just pain?
no, it is just pain.
Uh, did you notice anything increase this pain?
Um, no, doctors. Maybe when no, I had nothing which increases pain. It's a dull aching pain, and it is the first time that I can see that I experience this type of pain.
Okay. I'm sorry for that, Mr. Max. And we are, will try to help you as much as we can. Did you take anything for this pain? Any painkiller or anything?
Yes, I take some painkiller.
Is it improve the pain or no?
It improved it, but the pain returned.
Okay. Can you put this pain on a scale from 0 to 10?
I can say that it's 4.
Okay. Is this pain increased by movement uh, or decreased by movement?
No,
How
it can
movement affect?
decrease. It decreased by movement.
Decreased by movement?
Yes.
Which time in the day is this pain more?
This pain. I cannot get the question.
Do you feel this pain more in the morning or in the night?
It is more in the morning.
Do you feel any stiffness with this pain? Difficulty in movement?
Yes, maybe some little stiffness. Yes.
For how long does this stiffness last?
No, it is for minutes. It doesn't. It is not more than. It is for half an hour.
Any associated fever?
No,
Any lumps or bumps in any part in your body?
no.
Any change in your weight?
Any change in what?
In your weight?
No, there is no change in my weight.
Okay. Do you have any past history of concern? Do you take medication for anything?
Yes, I had before I had taken some medication because I have a history of clot, and this clot happened after I were coming from seeing my sister in Australia.
When this happened?
It happened 1 year. It happened last year, doctor.
This was the first time to have a clot?
Yes,
And what medication you take for it?
the doctor gave me some blood thinning medication, and then I become okay.
You are still on it now?
Yes,
Do you take any other medication other than this painkiller?
no,
I mean, blood thinner? No?
no,
Do you have any allergy to any medication?
no,
Do you take any herbal medication? A
no,
herbal substance?
no.
Okay. Do you have any family history of similar condition?
Yes, my father had something like this.
Like what?
He
Like
had
in
also
me?
some yes, he had also some clot formation.
Or do you have any soreness in your mouth?
Yes, doctor. I had soreness in my
Uh,
mouth, and it's very
n-
embarrassing.
now or before?
Yes, now I maybe now I'm good, but I had from a few months soreness in my mouth.
It is repeated soreness
Yes,
or
doctor, it's very
it was
embarrassing.
just
Yes.
once? Mm.
No, it's
Okay,
repeated.
I'm sorry for that, Mr.
Thank you.
Max. Do you have, sorry to ask you, do you have any soreness in your private areas?
Yes, doctor. Last year I had also in the soreness in the private area. It was very painful and embarrassing, doctor.
Okay, and how do you feel now?
No, now I'm okay. But now it's the first time that I have joint pain, doctor. It's something. It's the first time that I have joint pain. That's the problem.
I'm sorry for that, Mr. Max, and we are here today to help you. So, do you have any uh, uh, heart racing or chest heart racing? Heart racing?
No, I
Any
have no
heart
heart
racing?
racing. No,
Any
no,
chest pain?
no.
Any leg swelling?
Not now. But I had, as I told you, when I come from Australia, when I were visiting, when I was
Mm,
visiting my sister,
okay,
I had, and that's why the doctor gave me the blood thinning medication.
okay. Do you have any cough?
No, I had no cough.
Any coughing of blood?
No,
Uh, any shortness of breath?
no,
Any change in your vision?
not now. But it happened. It happened 2 years ago. I had some problems in my vision. But
Uh,
now I
what
am
ha
okay.
what happened from 2 years?
I had also some blurring in my vision, and uh, and doctor also gave me some medication.
Okay, it's like loss of vision or like what?
No, some difficulty in my vision, and
Okay,
I cannot see well.
okay. And now you
But
are
now I'm okay.
see what?
Yeah, no, yes, now
Okay.
I'm okay. After
Uh,
after the doctor give me some medication, and I become good.
okay. Any weakness anywhere in your body?
No,
Any abnormal sensation?
no,
Any change in your bowel motion?
no,
Any tummy pain or distension?
no,
Any change in your waterwork? Change in
No,
frequency, color? Hmm?
no.
Okay. Do you have any skin rash?
No, I have no skin. Yes, I'm gonna see you. Yes, I have uh, some rash in my in my chin, my chin.
Okay. Okay. Uh, any rash on areas exposed to sun,
No,
like in your face?
no.
Okay. I need to examine you now and let's see the lesion in your leg.
Yes,
I will start by vital signs.
yes,
Normal.
yes. Normal.
I will examine the knee by inspection. Any redness, swelling.
No,
I will palpate for any increased temperature.
no.
I will ask the patient, is there any pain now? If no, I will try to as if move the knee and feel any crepitations.
No.
Can you walk on it?
Uh, I can, but when I work on it, there is more. I feel some pain, but I can work on it.
Okay. Do you drive, Mr. Max?
Yes, I drive.
I recommending to you to stop driving until we reach to the diagnosis and give you the proper medication.
Okay, doctor.
Okay. What you do for a job, for living?
I am a teacher.
How this symptoms impacting your job and your daily life?
The joint pain actually, I really can take medication and I feel that I'm good and I can go to work. But when I return home, I just feel that I'm some sort of discomfort, and that's why I'm seeking medication
I'm sorry for
because I
that.
don't want to take a sick. I don't want to take a sick leave.
We will give you sick leave um, during your stay in hospital because we need to admit you. Do you smoke or drink alcohol?
No, doctor.
Okay. I will continue the examination now. I need to examine eye for
Uh,
for visual acuity
good.
first.
Mhm.
Visual field,
Good.
its shape movement.
Good.
I need to examine by fundoscopy eyes.
Normal.
I need to examine mouth for any ulcers or abnormality.
No.
I need to examine chest for auscultation and heart, chest and heart, breath sounds
Normal.
and heart.
Normal.
I need to examine the abdomen for any economically tenderness,
No.
calf muscles for any tenderness
Uh,
or swell, calf muscles.
calf muscles. No. Normal.
Okay. So, what's your concern, Mr. Max?
Doctor, what I have?
So after discussing with you and examining you, Mr. Max, I believe that you have a condition called Behçet disease that making some blood clots and affecting
2 minutes
the
left.
joints. But we need to run some investigations and some imaging study, and we need to admit you until we reach the diagnosis. Do you have any other concern?
Is it a curable disease, doctor?
Actually, it is not curable. There is no definitive treatment for it, but we can control the symptoms and prevent complications. by close follow up you regularly and if you need any medications.
Okay, thank you, doctor.
You're welcome.
Wait.
Uh, uh, I need so Mr. Max, I need to summarize what we say today. You have been from 2 days in your both knee that increase more in at rest, and you have and partial respond to painkillers, and you have past history of blood clot for which you're taking blood thinner, and you
Okay,
have
doctor,
also okay.
doctor, I want you to see my legs. There is some skin rash in it.
Show me,
Can I
please.
show it to you?
Yes, please.
I have on the WhatsApp. I put the picture on the WhatsApp.
Okay. Where?
Dr. Marwa, what do you think about this rash? What do you think this rash is?
It's erythromaldosis.
Okay, perfect. Time is up. So we can see this rash later. We can start now examiner question, Dr. Iman.
Okay. So can you summarize your finding, doctor, and say your diagnosis and your differential diagnosis?
My patient is Mr. Max, is 43 years old, complaining of bilateral pain in both knee, which for 2 days of acute onset, and partially respond to painkillers with past history of blood clot, DVT, and for which he taking blood thinner. Also, there is history of oral and genital ulcers, which are repeated. Also, there is skin rash, most probably erythromanodosum in his leg. I can't find any abnormality in chest and abdominal examination. My differential
Okay.
is Behçet disease. My first differential Behçet disease. Second differential hemoarthrosis because the patient take blood thinner. May other differential gouty arthritis or osteoarthritis.
Yes. Okay. So I'm gonna ask you something.
Okay.
Do you think what are the complications of Behçet disease?
The complications including repeated clotting and ulcers, most ulcers, and genital ulcers, arthritis, or arthralgia.
So I'm gonna ask you something else. You examine the eye. What are the findings that you are suspected to find in the eye?
I suspect to find any retinal vein thrombosis or or any not hemorrhage, thrombosis in retinal veins or arteries.
Yes, you're right. And when if the patient come with eye pain, okay,
Mm.
and you didn't find something with a fundoscope, so what will you think about or suggest?
Eye pain.
Yes, he had eye pain and eye discomfort, and he has reduced vision. But in spite of this, the fundoscope is normal.
Any corneal ulcer or dry eyes.
Actually, it is the interior uveitis, which is common in patients with
Really?
a Behçet disease.
Okay.
So the patient may come with reduced vision, or with some discomfort in his eye, or with some redness in his eye, And when you use the fundoscope, you find that it is normal. So it is you think about anterior uveitis. And as you said, that there is retinal vasculitis, yes, so there is retinal vein thrombosis, and you can also think in the eye about ischemic optic neuropathy or optic atrophy. So that are the three important things that you search in the eye problems in cases of Bassett. So you make examination of the other system. For example, when you examine your chest, you are searching for what?
If the patient have repeated pulmonary embolism, not with small pulmonary embolism, repeatedly have pulmonary hypertension.
Yes, and in the heart?
And the heart.
In the heart,
Ischemic.
you can think
Ischemic
about
heart.
pericarditis. Yes, even and even pericarditis, and really there may be sometimes there may be aortic regurg. So if I ask you, if you are looking in the GIT, you ask about the GIT, but what are you thinking about the GIT?
GIT may be indicated by mesenteric vascular occlusion if there is any abdominal pain.
Yes, they may come with colitis. And in those, and you had to think about when the patient come with colitis and also with eye pain, it can put another differential diagnosis in your list of differential diagnosis. What is this?
Ulcerative colitis may be associated with
yes, inflammatory bowel disease. It will be put in the list of your differential diagnosis. Okay, and there is something important that you didn't mention in the differential diagnosis of the Bassett disease, which is it is one of the list. No, think again, because you had in the history of mouse ulcers and
hemochromatosis.
No, mouse ulcers and clots.
Antiphospholipid with systemic lupus.
Yes, systemic lupus erythematosus and antiphospholipid antibody. It had to be put in the list of your differential diagnosis. Okay.
But the patient is male in last differential.
Yes, but does it exclude completely systemic lupus with antiphospholipid?
No.
Yes, so you had to put in the list of your differential diagnosis. Okay, so do you think that it's important to ask about CNS symptoms in those patients?
Yes.
Yes.
Or any complicated, I think there's meningitis and meningitis associated with this.
Yes, there is three things are important in the patient of Bassett disease in the CNAs, and you had to think about it and to ask about it. The patient may have jerking of the limb. He may have headache. He may have limb weakness. He may have, because you had an increased tendency of thrombosis, dural sinus thrombosis. And as you said, that he may have a septic meningitis.
Yes.
Okay, so what are the investigations that you are going to do to this patient, Dr. Marwa?
Firstly, we need to do basic investigations, CBC, CRP, or ESR. Also investigations searching for the cause, rheumatoid factor and CCB. This for blood, and also clotting factors will.
So if I told you that the Bassett disease is mainly we reach it mainly by the clinical diagnosis, can you tell me the criteria for the diagnosis of the criteria for diagnosis of Bassett disease?
History of blood clots with oral or genital ulcers, at least 3 times per year, I think.
Yes, recurrent mouth ulcers. The recurrent mouth ulcers is the main complaint. The patient had a history of recurrent mouth ulcer at least 3 times per year, plus 2 of the following: genital ulcer, eye problem, skin change, and there is a test which is important, which is the pathology test.
The surgery test.
Yes, you know the pathology test?
The skin test, are doing scratching to the skin and read after a few hours to see the marks on the skin.
Yes, it is. It will show with a skin prick or it will show small papule.
Mm.
Okay. Do you know that there is some tests which can be done in cases of Basset disease?
Test
Yeah.
other than pathology test.
Yes, it's laboratory.
Maybe we need to do protein C and protein S for any clotting condition, hypercoagulability condition.
Yes, you know the HLA. There is HLA which is specific for Basset disease.
HLA, B
Yes.
B52.
B51 and HLA B27 may sometimes be positive, but the most
51
important one
and
is HLA B51. Yes.
50. Okay.
So if I told you that how you treat, you think how they treat the cases of Basset disease?
Non-pharmacological management, including counseling, education, or regular follow-up, و pharmacological anticoagulant may be needed.
Yes, it will be needed for life.
Mm.
And
And medication for ulcers, oral
yes,
ulcers, mental ulcers.
you know what an important medication is the colchicine. Colchicine is important for
Colchicine, yes.
yes, to help with ulcers and arthritis. And you can also
Yes.
give a steroid. We can also give immune suppressive drug like azathioprine, and you can also give biological treatment like infliximab. Okay, so if the patient had interior uveitis, you know what the patient can take?
What's the patient? What?
For interior uveitis.
What's the
You know what is the treatment of interior uveitis in the patient of Basset disease? Yeah.
And actually, local steroids.
Yes, it's steroid eye drop, and if not helpful, if it's not helpful, if it is not helpful, he will take oral steroid, and if it's not helpful, if it is not helpful, he will take immune suppressive medication. So if I told you that we can do some imaging, if you are going to order some imaging for this patient, do you think what will be ordered?
Pulmonary angiography.
Yes. If the patient especially is coming with, if you are suspecting PE, he can do CT pulmonary
But
angio.
this patient, his complaint is knee pain, and imaging here will be X-ray for knee or MRI knee.
Yes, okay, thank you. Thank you. So we can ask Dr. Bassem, the professor, what he's going to say about this.
Yeah, good questions. Thank you, Dr. Iman, for preparing the topic. Now you comment first about her performance, what she did and what she did, correctly performed, how the performance, did she reach the diagnosis, any missed association, complication. Yeah, now you can comment. Then I will comment. Yeah.
Yes, she reached the diagnosis once she asked about the mouth ulcer, and I was insisting of bringing the case like this with joint pain. because it's also it's a little bit confusing. If you do not take the question systematically, we may lose a case like this. Okay,
Exactly.
because if you find a case of joint pain which is not associated with most of the rheumatological problems that we know, so you have to think about Behçet disease. And the clue was not only the mouth ulcers, because sometimes the patient of systemic lupus erythematosus can come with some arthralgia. So we are still here confused between the systemic lupus and the Behçet disease. But the clue was the genital ulcer actually, and then the history of the blood clot. I guess that she asked the most relevant question, which helped her to reach the diagnosis soon, and that's very good. It indicates that she practiced well. But I want to ask you something, Dr. Basim. Am I
Yes.
supposed to once she reads, really I'm confused in this in cases of Behçet. Once she reach that it is Behçet, is she supposed to in detail cover all the rheumatological disease?
No,
She had
it's
to
not.
do this?
No, it's
Yes.
not one
So
of the rheumatological association as a
yes. So I
disease.
guess yes. So I guess that she did it well. It was a good
Yeah,
performance.
yeah.
Thank
You
you,
can ask
Dr.
the systemic review, but it's not a must to have systemic lupus, rheumatoid, or whatever. This is one of the seronegative, right? It's one of the
Yes.
seronegative arthritis. So it's not
Yeah.
important, or it's not as a must. You have to ask about other rheumatological, but you can ask any muscle pain, any back pain, any stiffness, because this is joint system or musculoskeletal system. But it's not necessary to ask about SLE association or other rheumatological condition association as overlap, for example. Okay.
Yes.
Yeah, and the
So
nature of the pain here is important, as Dr. Marwa asked. Is it worse with the movement or improve with the movement? Or at the opposite, improve with the wrist or worse with the wrist? It will help you to know this is either mechanical pain or rheumatological pain.
it is still in Behçet disease rheumatological pain, isn't it right, doctor?
Inflammatory, yes, it's inflammatory. Yeah, it's inflammatory one. It's not mechanical one.
Yes. And doctor, it comes with arthralgia more than arthritis?
Um, Arthralgia or arthritis, I don't think it's arthritis. I don't think there is joint change. Only
Yes.
pain. Only pain. It's not,
Yes.
yeah, it's not finding or a change in the joint itself. So it's as a joint
Yes.
pain and veno occlusive, or sorry, veno thrombosis, I mean, venothromboembolic disease. Venous or arterial, right? It happened in
Mhm.
both. And in Behçet, it happened in both, yes. Thromboembolic disease. Another finding, as you mentioned, the oral and genital ulcer. It's very important in the history taking. Plus examination. You can offer examining the genitalia, Dr. Maro. Offer
Mhm.
it, but don't rush to examine it. You can offer to examine it if there is rash. The also rash you have to examine the erythema nodosum and to describe it to the patient or to the examiner when you describe the skin lesion. Okay.
I once heard a doctor who said,
Yeah.
if you find joint pain with no deformity in hand, joint pain with no deformity of the systemic sclerosis, joint pain with no skin rash, or any history of skin rash, search for mouth ulcer and for ulcer in private area immediately.
Yeah, you're right. You're right. I think Doctor.
Dr. Basim,
Yeah, yeah,
I really gonna say something, but
yeah, sure.
really, I will never offer to examine the genitalia, because if they told me go and do it, I will lose the rest of the exam.
No, no, it's just an inspection. By the way, you will not do it in details or details examine, and no one will allow you to examine the patient for the genitalia. Why? Because it's against the welfare. But offer
Yes.
it. Why you offer it? What the meaning and what the difference between offer and examine? Offer, you want to know
Offer.
it. Yeah, tell me, yes.
Offer, that means that I want to make the examiner know that
Exactly. Yeah.
I know
So
but
yeah, I'm showing the examiner I am concerning about something in this area,
okay.
whatever it is. Or even sometimes you have to offer some tests if you don't have time. For example, I am examining now the rheumatological disease, the previous case, for example, rheumatoid arthritis. I don't have time to examine pulmonary hypertension signs. I can offer it. If I have time, can I examine for pulmonary hypertension signs and symptoms like this? So you can offer if you are feeling it's embarrassing to the patient, or if you don't have time to do it. But don't tell the examiner I offer examining the hand for rheumatoid arthritis. Of course, you have to examine it without offering, right? Look, feel, move. You have to examine. What I mean, something you have to examine, and others you can offer to examine them. Lymph node in the inguinal area. Is it something you have to examine?
No.
Yeah, so you will offer it. Why? Because it's against the welfare. But you will offer it. If he allowed you, you go in. In my exam, it was lymphoma, and I offered to examine every single lymph node group. And when I reached the inguinal, they said, yeah, go ahead. I examined the inguinal lymph nodes. But you have to offer it. Why? Because you are in private area. This is the way how to get the marks for the welfare and to show the examiner that I want to show you that I know that I am doing this to pick up a finding here.
Okay.
Genital ulcer, one of the finding, it might be there. And if you offer it, either he will tell you go ahead or no need. If he said no need, be sure that it is not there. If he said go ahead or do it, you might have it. So they will not expose the patient to the embarrassing exam or test unless there is finding. Okay, but you have to offer it.
Okay.
Other question, Dr. Iman?
No, thank you.
Okay, back to the performance for Dr. Marwa. What we missed in the previous case, Dr. Iman, the constitutional symptoms. You didn't ask about fever, loss of weight, loss of appetite. Dr. Marwa did in this scenario, which is great. I also forget to mention it to you. In connective tissue disease, believe me, you might have loss of weight and loss of appetite. Some patients, they will have loss of weight and loss of appetite. Any connective tissue disease. So you have loss of weight, either cancer, HIV, or connective tissue disease. Dizziness, also you can ask either in the previous case or in this scenario as also anemia of chronic disease. Based one of them. Amyloidosis is important as genitourinary. I'm just summarizing if something missed by Dr. Marwa or no, I'm not sure, but she covered well. I think she started as a systemic review from the head. I think you asked about CNS, Dr. Marwa, right? Headache, neurological, weakness, pins and needles. You ask or no? No. Yes, okay, perfect. That's good. Whenever you finish the analysis of the complaint and the relevant system, plus past medical history, constitutional symptoms, you want to start systemic review. Imagine the patient body, the head and downward to the toe. Every system presented by one question or two or maximum three questions. For example, in the cardiovascular, you mentioned here that chest pain is very important. Chest pain means coronary artery disease, and it's one of the association. This patient might have ischemic heart disease, awareness of heartbeat in anemia, for example. Chest pain as pericarditis, yes, one of the important might be associated, so you have to ask about. And the chest here is important as well, pleurisy. You might have pleurisy if he has chest pain. Short of breath as a pleurisy also might be there. Cough and short of breath we mentioned already. The cough of blood, yes, is very important question Dr. Marwa asked. Why? Because pulmonary embolism, one of the possible finding, patient might have hemoptysis, right? Especially massive pulmonary embolism. The tummy here is important to ask about tummy pain. Why tummy pain? As any patient with a vaso-occlusive or venothromboembolic event or thromboembolic event, either arterial or venous, this patient might have mesenteric ischemia or a blood clot to the mesenteric vessels. So he might have tummy pain. You have to ask about tummy pain, tummy distension, change of the bowel habit. As Dr. Iman said, there is possibility as association with VISIT, you might have inflammatory bowel disease. So he might present with diarrhea or loose motion. Along with that, you have to ask about passing blood through the back passage as inflammatory bowel or as a mesenteric ischemia. Okay, it's important question here as well. Musculoskeletal, of course, analyzed before with the relevant system. Because the joint pain means you have to ask about the musculoskeletal, including the joint, the pain itself, the onset course duration, previous attack, and the stiffness, back pain, along with other joint pain. Then you can ask about the skin rash. This is the meaning of musculoskeletal system: skin and joint, and muscle, of course. I think Dr. Iman covered the whole question for BIHSIT, pathology test, how to do the investigation, specific investigation, HLA, B27 and B51, and I think more specific B51 for BIHSIT. ESR, inflammatory markers, is very important to mention in any rheumatological condition. Inflammatory markers could be high, ESR, CRP, with the activity of the disease. And the other investigation for the complication here as a specific test, D-dimer. This patient had pulmonary embolism, so you have to mention D-dimer. Although it's good negative test, but you can mention it as a negative test for pulmonary embolism. You can also mention the ultrasound Doppler as bedside test to rule out DVT, which is the case. I think it was DVT previously. It might be shower to the lung, show pulmonary embolism. I think these are the possible investigation. Dr. Marwa, whenever you start managing the patients, you mentioned multidisciplinary team, which is good. Don't forget non-pharmacological education counseling about disease and the condition. This patient might receive the anticoagulant as lifelong. So it's one of the education here. Apart from the pharmacological, you have to give time to the non-pharmacological therapy, education counseling, how to manage this disease with the patient. He will present with recurrent mouth sores, recurrent genital ulcer, how to treat this, how to deal with this. It's painful ulcer, right? So you have to give him some painkiller, topical or steroid topical to the mouth to help him in this pain. Plus the complication of DVT or the pulmonary embolism or the clots, blood clot, recurrent thrombosis, the patient might kept on anticoagulant. And with the recurrence of the pulmonary embolism or the thromboembolism, you might elevate or you might have high target of INR, for example, from 3 to 4. If he has first pulmonary embolism or first thromboembolism, you can start by 2 to 3. With the recurrent, you can raise it to target 3 to 4. And of course, lifelong. Okay, so take time to explain about education and counseling. It's important. You have to sit with the patient to inform him about his management plan. It's not a matter of giving medication only, no. I have to sit with the patient how to deal with his life, how to deal with these symptoms and signs, even the skin rash, how he deal with it. Okay. Plus the multidisciplinary team approach, of course, dermatology, rheumatology, and nephrologist. Most of basic disease end up with dialysis. Why? Because of either the amyloidosis as association, or even the anti-inflammatory medication, analgesic nephropathy. Those patients might have or end up with end-stage renal disease, and they will be dependent on dialysis. So you have to counsel him how to avoid all these complications. You have to seek medical advice before starting any medication for the pain or the joint pain. Clear, Dr. Marwa? And Dr. Iman, any question?
Yes, Dr. Marwa, she a little bit excluded systemic lupus erythematosus associated with antiphospholipid because she was a male. Is it a true concern or not?
No, it's okay. You have to rule out it. It's not a must to be female.
Yes.
Yeah, it's common in female, but it happened. What the rate? I think it was 9 to 1, right? 9 to 1 SLE. Or it
Yes,
was
but
another
that is
disease.
excluded even if it is a male. And I think that Behcet is more common in male.
In males, yes, yeah. So
Yes.
you give differential to the top of the diagnosis, which makes sense. But still, you have to think about others. So don't say it's only base it without thinking about systemic lupus, because systemic lupus comes with mouth sores, right?
Okay,
Clear?
doctor. Thank you.
Okay.
Yes,
Any
it's
question,
clear.
Dr.
Thank you.
Yeah, thank you, Dr. Iman. Any question, Dr. Marwa? Any suggestion? Yeah, Dr. Marwa, go ahead. Mesenteric vein occlusion, yes. Okay, many thanks. Thank you too. Any question from other? Dr. Aisha, you want to add anything? Anyone want to add any concern, any question, any missed point? Thrombophlebitis is one of the possible association. You have also to mention it, thrombophlebitis. So the patient might have painful veins, and the clots in this patient, it might be superficial, not deep, but it happen in all veins and arteries. It's one of the arterial and venous thromboembolism disease. Okay, thank you, Dr. Aisha. Any question by
Uh,
others? Yes.
yes, doctor. Thrombophlebitis from DVT. How I can differentiate them very rapidly in the history or the examination? Because
It's
I'm not good in
radiological.
clinical examination.
Radiological. It's radiological issue. The deep venous thrombosis will be examined by the ultrasound Doppler, right?
Yes, okay. But clinically, they are a little bit the same or something like this. We cannot exclude it completely.
You will have, I think, you will have both in both disease. You will have swelling in both edema, I mean, and it will be unilateral. But with the superficial thrombophlebitis, you will have redness and inflammation in the vein across the vein uh, course.
Okay.
And also, as Dr. Aisha said, it will be painful. Yes, it will be painful with the thrombophlebitis. DVT might be painless. Yes, perfect.
Okay, doctor.
And
Thank you.
and other thing, radiological. So the DVT will be diagnosed by radiological finding as ultrasound Doppler. Okay.
Okay, doctor. Thank you.
Most welcome, Dr. Iman. Any other question before finish or ending this session? Okay. Thank you for participation today, Dr. Iman and Dr. Marwa. Thank you for attendance from others. Yeah, I know the numbers is not as before, but still we are holding. We will insist to persist surviving decision as much as I can. Even during my vacation, I will try my best to do at least one session per week, either for the long or short. I will try to do it in arrangement with whosoever want to practice. Anyone want to practice, he can find a partner. They can send me because this session might be the last long clinical consultation before my flight. My flight after tomorrow. So in the next week, I'll be in vacation. But if someone want to participate and he has a partner ready to participate, send me both of you that you are ready, and I can run the session even once weekly in order not to lose the progress of these sessions. At least we'll do once a week, long and communication. Okay. Anyone has the wish to participate, please find a partner and message me. Then we can run the session. Otherwise, I will wait for these messages. Okay.
So, Dr. Basim, it's only during your vacation or
Yeah, I will do, or I will run one session according to the participation. If there is participants, two participants, not only one, ready to participate, they can send me at
okay,
least once weekly, at least. So if they are participating once weekly, it's okay. If more, I will try to arrange another session. So whosoever ready to participate, send me with a partner. I have a partner to participate. Then I will tell you what day we can participate and what day we can do the session, run the session, and we'll do it at least once weekly in order not to cut the progress of the sessions. Okay.
okay, Dr. Basim. And when you will finish your vacation, doctor?
Maybe after at the middle of July. So
Okay,
again, every week,
Mm.
if you are ready, Dr. Iman, to participate any day, let me
okay,
know if you are ready. With Dr. Marwa, for example, send me a message. We are ready to participate. I will tell you what day we can do the session,
okay,
and for two sessions, for example, long and communication, we will do at least per week one session for the long, one session for the communication, and I will say what day we can do it suit for me. Okay.
okay, okay, doctor. Thank you.
Okay. Most welcome, Dr. Iman. Thank you, everyone. See you tomorrow with the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh. جزاك الله خير
عليكم
دكتور
السلام.
أحمد.
Thank you.
الله يسعدك. Thank you for your wish. Thank you.